Good afternoon and welcome. My name is Jane Lewis. I am Chair of the Hospice Palliative Care Association of Cape Breton County. And on behalf of our society, our sponsors, and our partner Cape Breton University, we are delighted to welcome you to this afternoon's session, which, as you already know, is going to feature internationally renowned expert in dignity and care in end-of-life care, Dr. Harvey Max Chochinov. Before I introduce Dr. Chochinov, I want to let you know who we are and what we're doing here today. Our society has been in place in this community as a non-profit volunteer entity for almost 40 years. And we have been promoting and supporting preeminent end-of-life care for those facing life-limiting illnesses and trying to support their families on that journey for all of that time. We work closely with our partners at Nova Scotia Health, who provide the exemplary clinical care across many settings in our community. And that many settings in our community is an important thing I want you to think about and remember. Because although people tend to remember and think about the fact that we have a 9-bed unit that's called Oncala in our regional hospital, and that we have a 10-bed hospice building that we're very proud of on Charles Henry Otway Way, which is the road from the regional down towards Membertou, if you haven't been there. But those are only a small percentage of the beds and the care that's really being provided in our community. At any given time, there's 200 to 250 individuals who are receiving palliative care service in Cape Breton County. That's a lot of people, and it's very important and good work. I can share that many people involved in our board are there because their own lives have been touched by palliative care. And just very briefly, I want to say mine was one. And my own mother died in 2013. She was 94. She died at home of natural causes, actually in my arms. And the only reason why that was possible is because of the very good palliative care and support in this community. And I remember it's why I ended up being a volunteer for the board. And I remember saying at that time, and I think it holds true, that although there are many areas of challenge in the Nova Scotia healthcare system, and we all know people are trying to do more with less, and there's a lot of pressure on the system, that palliative care in Cape Breton is not broken. It wasn't then, and it's not now. And I think we can be very proud of the exemplary work that's done by our Nova Scotia health professionals in this area. We certainly appreciate the excellent work that NSCC does in the preparations of our healthcare professionals of tomorrow, and glad to see some students here, and anxious for you to learn a little bit more about this field of medicine that is so challenging and so rewarding and so important. And we're also very happy to be hosted today by NSCC in this beautiful theater. It's our first time using the theater, and it won't be our last, I'm sure. I was privileged already to hear Dr. Chochinov this morning, so I know you're in for a treat. And our plan is that after he speaks, we should have time for some questions at the end. Dr. Harvey Max Chochinov is a distinguished professor of psychiatry at the University of Manitoba and a senior scientist at the Cancer Care Manitoba Research Institute. His research offers new insights on palliative care and person-centered care. He has more than 350 career publications and 30,000 citations of those publications around the world. And his work has addressed such topics as depression, quality of life, suicide, vulnerability, spirituality, and existential distress towards end of life. You know, I've had the pleasure of speaking to Dr. Chochinov a number of times as we prepared for this event, and in our conversations, he would remind me, more than once, I'm a slow learner, that his areas of expertise are not really just related or confined to hospice or palliative care, that this sort of person-centered, compassionate kind of care applies to everyone in the healthcare system and those providing care outside of the healthcare system too. Dr. Chochinov has also led a large program of research on dignity in the healthcare setting, which includes the development and study of a topic that sounds fascinating to be dignity therapy. He is co-editor of the Handbook of Psychiatry and Palliative Medicine, Oxford University Press, and his latest book, entitled Dignity in Care, The Human Side of Medicine, also published by Oxford University Press, will be released in November. He has been the recipient of numerous honors and awards, including the Canadian Medical Association's highest recognition, the FNG Star Award. He is a recipient of the Order of Manitoba and is an officer of the Order of Canada. In 2020, he was inducted into the Canadian Medical Hall of Fame. I know you will help me give Dr. Chochinov a warm Cape Breton welcome.
Hello, everyone, and welcome. And speaking of welcome, I feel welcome. Just by a show of hands, how many people were at this session this morning? Oh my God, you're stalking me. And now I have to gauge which jokes I can not tell or try and tell again and hope that they just go over better a second time round. All right. Today, this afternoon, I'm going to be talking to you about this notion of, why being a patient is such a difficult pill to swallow. And I imagine, and I'm hoping that because this is a public lecture, that some folks out there would see themselves as patients and have grappled with this notion of what is it about being a patient that's so difficult. I thought I would begin by sort of bringing this home in a way, and that is the artist Robert Pope. My understanding is that he was born in Hansport in Nova Scotia. In the palliative care world, this man is very well known, and his paintings, his work is really very revered. During the course of his own illness that eventually led to his death, he produced sort of a magnificent series of paintings. And I thought to begin, I would just show you kind of a handful of them, because I think they begin to answer the question, what is it about being a patient that makes it such a difficult pill to swallow? This first one, you'll notice the first thing is that the patient is in the background. The patient is difficult to see. And I think there's something to be said about that. Being a patient makes it difficult to be seen. And we're going to be kind of revisiting that theme time and again. Being a patient is also isolating. Even if you are surrounded by your friends and your family, it is an experience you essentially feel oftentimes that you're going through in many ways alone. In spite of the fact that you may be well supported, there is an internal experience of illness that has to be navigated, and each of us end up having to do that in our own particular way. The other thing is that, in spite of my remarks about isolation, all of us live in a community. All of us have people who care about us, and our illness has ripple effects across the entirety of all those who do care about us. So illness affects patients, it affects families, it affects communities. And it's why when we talk about palliative care and the focus of palliative care, the unit of care in palliative care we talk about as being the patient and the family. So the first kind of insights about the difficulty of being a patient came by way of sort of looking at a situation where, beyond a doubt, patients were struggling. And what is the epitome of struggle? Well, the epitome of struggle is feeling, I just don't know if I can go on like this. That's sort of abject suffering, isn't it? When you feel like, as I had a patient years ago who told me, he said, breathing has become redundant. He was a very wise and well-spoken gentleman. But the idea that he had reached a point in his life where he felt there was no further point in going on living. So that is the epitome in terms of an example of somebody who's feeling that patienthood is a tremendous struggle. So we turned to the Benelux countries where euthanasia and assisted suicide had been taking place for many, many years. This is several decades before Carter versus Canada, to try and find out the psychology, the explanation. What is it that is happening to people who feel not only theoretically, but in fact can't go on and choose not to go on because of the availability in these jurisdictions of a hastened death, either by way of euthanasia, and euthanasia is a lethal injection of a medication, or assisted suicide, which is somebody receiving a script for a drug that person can use at a time of their choosing. So that is the differentiation. So we were fortunate enough to discover this study by Paul van der Mes. Paul van der Mes was a physician who was commissioned by the Dutch government to find out not only how often people were availing themselves of this, but why. And this is where a sense of lost dignity first came onto our radar. According to these Dutch physicians, more so than any other reason, people who said their dignity was kind of fractured, their dignity was violated, chose for that reason to end their lives. So if we're thinking about, well, why is being a patient such a difficult pill to swallow? Dignity begins to provide some insights. There is something about the violation of dignity that undermines our ability to carry on. It makes it a difficult course to follow. We did some studies, and again, any of the numbers that you see up there are inconsequential. You don't need to remember them. And for those of you who are interested in kind of delving into the details, all of my articles are open access, so you can go to PubMed, or you can go to dignityandcare.ca, and you'll find all of the articles. And if you can't find them after that, email me and I'll send you a PDF of whatever article you might like. So this was a study, and as it happens, it was the first study ever published on the issue of dignity in the terminally ill. Maybe just backing up, I should say that when you're going to begin any study, you start by looking at the literature. And at this time, and this was well over 20 years ago, dignity is cited everywhere. People talk about dignity, but it's a very politicized term. In other words, let's say whatever contentious position you might support, ultimately the argument you would argue is this is a dignity issue. So for instance, if you were for assisted death, if you thought this was about autonomy, this is your body, your decisions, you would say, well, ultimately, this is a dignity issue. And that's a very powerful and profound argument. And if you're on the opposite side of that political fence, you would say, this is the undermining of the patient-physician relationship. This is a violation of the Hippocratic Oath, the taking of human life. This is an assault on human dignity. We said, we're not the moral police here. We come at this as clinicians who are interested in doing some objective research. So we wanted to go to the bedside of patients and find out, so what is this all about? Okay, so this is the first study that reported what this is all about. And what this study of over 200 patients receiving palliative care said is that half of them, dignity was not a major issue, which means that at least occasionally for all of the folks that I see in my practice, and those of you who are in palliative care, this is a significant issue. And even knowing that some of you have heard me say this before, it's nuanced enough that it's worth repeating, because this was, for me, kind of one of my first, what I think of as kind of a research epiphany. When we studied dignity, we were able to look at all kinds of things that might influence it. And, whether people, and we thought, well, what are the things that make it hard to be a patient? Well, if you're in pain, that makes it hard to be a patient. nausea, shortness of breath, all kinds of physical experiences, lack of feeling supported, depression. All of these things might make the pathway of patienthood a really hard pathway. At the end of the day, when we looked at our data and said, well, is there some hierarchy of importance? Like, what more than anything, according to the data, this isn't our opinions, according to the data, what is most predictive of lost sense of dignity? And this is where this unexpected finding of appearance, or how people saw themselves to be seen, emerged as the most significant predictor of dignity. And so in this article, Dignity in the Eye of the Beholder, what I say is that patients need to look in the eye of whoever's looking after them and see a reflection that will affirm who they are. And I think if we're talking about why is it hard to be a patient, it's hard to be a patient because it means that you're not fully seen. To be seen as exclusively a patient means that you are seen based on some biological or physiological parameters, And we even organize our healthcare system that way. There's the heart clinic, and there's the nephrology clinic, and there's the neurology clinic. We are kind of siphoned off into these different pathways based on, what inside of our body is acting kind of wonky. And so it's hard to be a patient when you feel that you have now kind of been reduced to and even classified based on, what particular organ or system inside of your body is acting wonky. And as I said this morning, it's ironic because we train all of our lives to look after patients, and nobody wants to be seen as just a patient, because it's a generic term. A patient is a generic term based on kind of a classification of what ails you. Personhood, on the other hand, is the antithesis of that. It is uniquely you. There's never been one like you, nor will there ever be one like you. So this particular photograph is an etching by M.C. Escher, and it's a self-portrait. You see the artist reflected in the eye of, I choose to call it the provider, and it's an affirmation. What happens in medicine, and for anybody, all of us in this room, whether you're a healthcare provider, as long as you've got a pulse, you have been a patient at some point in your life. And when you walk into the examination room, you've likely had that experience where you become reduced to, whatever's brought you to medical attention. And that's uncomfortable when it's at the exclusion of, I'm still me. And I've written about this as sort of the hazard of patienthood eclipsing personhood. So in much of my writing, and again, it sounds like I've maybe being a little bit too kind of reductionistic. If how we see people matters, then we need to think about, as healthcare providers, what goes on inside of our head. Because if we don't think about that, every time we're with a patient, they're going to feel like somehow the essence of who they are has just kind of gone off the radar. And again, it can happen, quickly. I remember years ago, I had to go into the hospital for a dental procedure. It happened to require general anesthesia. So at 3:00 in the afternoon, I'm in the car, I'm driving, fully autonomous, heading to the hospital. By 3:15, I'm naked on a gurney with a gown that refuses to stay done up at the back. All jewelry is gone. Anything that that might distinguish me as any one body from another is completely gone. It happens quickly. That's what makes being a patient difficult to swallow. Now, for me, the procedure was over quickly. I got dressed, and you put your clothes back on, and your personhood is regained. There are many instances where being a patient becomes something that is much more chronic, much more kind of ubiquitous, and that has to be dealt with. And it comes down to this. We tend to, in medicine, we tend to think about medicine, and we organize medicine in a very transactional way. we do stuff to people. We give them drugs, we give them radiation, we give them surgery. Those are the things that we think about when we think about medical care. And it's kind of transactional, very objective, very generic. So from the outside, we in healthcare learn about physiology and pathophysiology, and we think about diagnosis and problem checklists and treatment plans and the like. At the center of it all, we have to remember there's a person, and that's not an easy place to be. Those walls look pretty high. It's pretty hard to see beyond them, and it's pretty hard to feel that you are seen or acknowledged. Again, this is another painting by Robert Pope, and I like this particular one because it is, in my mind, an image of somebody teetering on the surface of the water, and you think about what is going to pull them under, what is going to keep them buoyant, and understanding those various different forces, be they physical, psychological, existential, spiritual, environmental. Understanding those forces is the essence from a healthcare provider perspective to providing holistic care. But in being a patient, those are the things that we want attended to if we feel that personhood is going to somehow remain intact. I told this story briefly this morning, and I'll say it again just because this is a picture of a colleague, and his name is Stuart Farber. He was a palliative care doc in Washington State. And when he was approaching end of life, he talked about a metaphor that he used, that he described as his thread. So he said, with rare exception, the clinicians who treat me have good hearts, care deeply, possess little or no knowledge of my thread. So it's a metaphor for the essence of who I am. And he says, quote, without knowing my thread, it's impossible for a clinician to provide respectful care. So this is the other thing about being a patient. We enter into patienthood, and does personhood somehow get left out in the waiting room? It's not as if we want our care providers to know every detail of our lives. It's not like we expect them to be able to reproduce a carefully constructed biography, but to know our thread, what makes us tick, kind of the essence of who we are. It turns out that that's a pretty profound thing for patients, and we have evidence that shows that in the absence of knowing that, it kind of yields a state of brokenness. People feel somehow fractured if they feel that their essence, their thread has been broken. Lately, I've actually been writing about this. This is one of those instances, by the way, where even though I've spent all of my life, professional life, looking at issues in palliative care, you find out that people near the end of life, this is a big surprise, people at the end of life are still people. They just happen to be in a place where they may be closer to the end than the rest of us. We're all going to have our turn. But in that place, they can provide insights that are just very helpful. And what we found out from our patients is that no longer feeling like the person I once was a profound and prominent existential state of being. I think it was nearly like about 40% in our cohort of patients who felt like I no longer feel like me. And, in palliative care, quite routinely, you're not going to get through a day, and sometimes maybe not even get through an hour without being asked about, your pain, your bowel movements. Asking about personhood, obviously from the data, we need to become much more mindful of that. It's important for healthcare providers, and it's important for patients and their families to have that kind of acknowledgement. So the interesting thing about this then is we've kind of carried this forward and say, well, if feeling broken is related to a sense of no longer wanting to go on at end of life, what about at other times of life? Might it explain something about suicidality, writ large? And so we published a study, not more than, I didn't include the study, but we published a study just a few months ago in the Canadian Psychiatric Journal, in which we measured using an instrument we've developed called the Patient Dignity Inventory. So measuring what we call dignity-related distress, we have found that dignity, a sense of dignity, which is all about being acknowledged, being seen, being known for who you are, directly correlated with depression and suicidality. And this wasn't done in palliative care. This was in an inpatient psychiatric facility. So it says to me that dignity and the issues that it implicates, it's important across the life cycle. You know, if you're thinking about suicide and suicide prevention, if you're thinking why people might be feeling despondent, understanding these dynamics of human dignity from the data seems to be an important point. I talked about this more this morning. I'm just going to touch on it, and that is that, again, I'm thinking about the patients who are here. What is it the patients want? I call this the ABCDs of dignity conserving care. We want a healthcare provider who's absolutely competent and proficient, understands all of the transactional pieces, but we also want somebody who we feel we can have some kind of relational connection with. We're not looking to make, to be best buddies with, or to go out for coffee or a drink afterwards, but we want at least to feel like we are seen and acknowledged. So this particular paper says to healthcare providers, this should be part of your core efficiencies as a healthcare provider. Besides all the other transactional things you've learned in medical school, you need to know that your attitude towards patients is going to make a difference. Again, not says me, says the data. I've already showed you how our outlook shapes human experience in clinical encounters in profound ways. B, behavior. Do you sit? Do you stand? Do you meet someone's gaze? Do you not meet someone's gaze? Just put a hand on a shoulder. I love this little anecdote because it just shows how nuanced and simple this can be. I was walking into the washroom. The door beside me is the doorway of the clinic of James Johnson, who is a hematologist oncologist. As the two doors are closing, the last thing I hear James Johnson say to his patient is, "So, how was that vacation?" I can guarantee you by the time I came out of the washroom 2 minutes later, they were not sitting in there looking through a photograph album of the vacation. But it acknowledges that although although lymphoma may not take a vacation, patients do, okay? So it doesn't have to be complicated. C is for compassion. Compassion is the understanding of the suffering of another person. You can't try and address or understand or be compassionate without understanding some essence of the person and an attempt to respond to it. And D is for dialogue. These are conversations that patients want to have, and they needn't be lengthy, but they need to acknowledge that I am a person with an ailment bringing me to medical attention. So we've looked at different ways of trying to put patienthood on the radar. Some of them are very simple, and I'll tell you about that in a moment, and some of them are more detailed. They require more kind of resources and training. One of the innovations that we came up with years ago was something called dignity therapy. It was mentioned in the introduction. Dignity therapy, in essence, guides a patient through a conversation that is recorded and transcribed and edited that allows them to create a legacy document. Dignity therapy has become the most studied non-pharmacologic intervention in palliative care today. I mean, this book is being translated into multiple languages in very different places across the world. And yet what's interesting is it seems to resonate with people. And Corey and I were having a conversation today on the way down here saying, we tend to think about, the world and how much divides us and how people are different in different places based on all kinds of geopolitical things and things that separate us. When it comes to these issues like dignity, dignity therapy, we create a document, it is transcribed and edited and returned to the person. It's a way of helping a person feel that something of who they are will somehow even transcend death. That, your being here made a difference. And dignity therapy is a way of somehow being able to document, that difference, or at least what you would want known, what you would want to eventually leave behind. Okay, a far simpler approach that we've also developed is what I've called the patient dignity question, or the PDQ. And it's pretty simple. It's not rocket science, but it has profound impacts. What should I know about you as a person to help me take the best care of you that I can? When's the last time as a patient anybody asked you that? And sometimes, what I'm hearing from some colleagues is they'll say, I'm trying it, and patients don't get it. And I say, well, what do you mean? He says, well, I asked them the question, and they don't understand how they're supposed to respond because they don't see it as a medical question. Now, of course, what I say is, well, it is meant to be the beginning of a conversation. And so when people don't understand, say, well, what I really want to know is, I know a lot about the things that are in your chart, but I would like to know, how is it that you would like to be known? What would you like anybody who walks into this room looking after you to be aware of in terms of who you are as a person? We have a brief conversation, anywhere from 5 to 10, 15 minutes at the outside. We go off and summarize that into a few paragraphs. We come back to read it, let them edit it, and the litmus test, do you want that on your chart? We've studied hundreds, and now in the literature there are thousands of people who have been studied using this approach. I have never, ever heard an instance where somebody said, those few paragraphs that describe exactly how I would want people to see me? No, I don't want you putting that on my chart. It just doesn't happen. And it can be done by proxy. Families can also do this, and it works very effectively. The family members saying, in fact, we just did a study during COVID in which we did this with family members of people who were in intensive care, either on ventilators or unconscious, and it worked beautifully. And in fact, the paper is the last of the last revisions is done, and we're just waiting for the journal to say yes, it's been accepted for publication. So that will be forthcoming. I also talked this morning, and I think it would be helpful for any patients here to kind of review this, and that is that, we as healthcare providers are only human, and we have been shaped in ways that we aren't always entirely conscious of or aware of, but our outlook as a healthcare provider shapes the way we are in this world. The way we are with other people and the way we are with patients. And intuitively, we tend to respond to people based on, the golden rule. Now, if I were in your shoes, this is what I think I would want. If this was my, husband, wife, if this was somebody that I loved, a member of my family, this is what I think should happen in those instances. And what I've pointed out is that the golden rule is, it's an important moral adage that you find in religious traditions across millennia. But it has limitations because it does impose this external standard. It's saying that, we expect somehow the healthcare provider to be this kind of barometer of what you, the patient, needs. And that can lead to what we would refer to, or what I would refer to as kind of therapeutic nihilism. So, and by that I mean, what if there's an encounter and the doctor is saying to himself, geez, if that were me, would I want to be that old, that sick, that marginalized, that disenfranchised, whatever it is that might shape that person's lens, and then lead to a recommendation that may be at odds with what the patient wants, which of course makes being a patient, a difficult pill to swallow. So because of that, I had introduced, and I've got a couple of papers in the last few years on what I call the platinum rule, which simply says your lens is important, but the more important lens is the patient, doing unto patients as they would want done unto themselves, which doesn't, by the way, mean everybody gets all things at all times, but it does mean we need to acknowledge the patient's perspective. I told the story this morning, and I'll tell it again, of my sister Ellen. She had cerebral palsy. She died at 55 about 10 years ago. And when she was admitted to an intensive care unit several years before her death, she was on the brink of kind of this respiratory collapse, and a decision had to be made. So what are we going to do? And the intensivist came up to me and asked me only one question about personhood, which was, does she read magazines? And it struck me as kind of a weird and wonky question. What does that have to do with anything? Like, we're freaking out here. My sister's on the brink of life and death. And I realized the problem was he wasn't able to see Ellen. He saw her kyphosis and scoliosis. He saw her falling blood gases and her respiratory distress, but he didn't see Ellen, the human being, who had a complex but very rich life. And so I said to him, well, yes, she does read magazines, except when she's in between novels. So these are the merits of the platinum rule. It means, we need to figure out, our own biases, that, life has shaped us in ways that we may not even be aware of, but it accounts for our perceptions, our judgments, how we approach patients and clinical care. So let me take the last few minutes, if I might, to talk about something that I think, hopefully will be of interest, and that is, all of us who have lived long enough, or who have practiced medicine, if they're, for those of us who are in healthcare, know that not everything lends itself well to the traditional medical paradigm, which is we examine stuff, we diagnose stuff, and we fix stuff. And in life, it sometimes works that way. It's great for treating a pneumonia, but not everything in life lends itself well to that model. So, and yet, in healthcare, there are so many things that come to our attention that aren't fixable in the way that you can prescribe a drug for pneumonia, and then if you look at a clean scan and say, well, that felt really good. So unless we say, well, what, if those of us who wear the medical hat say, well, that's really not our business anymore. That's one way of dealing with it, to say, what, if I don't have something that's going to fix it, then it's not in my lane. Go talk to your pastoral care provider or find a counselor somewhere to talk to. But I'm here to medicate, to radiate, to cut it out. And other than that, it's just not in my lane. Well, that leads to a very limited scope of practice, and it means that there's a whole lot of people whose angst and anguish you are basically going to dismiss, and that's going to make patienthood, a difficult pill to swallow. So what I've been writing about lately, let me just see what I have here. Yeah. So what I've been writing about lately is what I call intensive caring. So when you're in a really bad way, physically, we give you intensive care. Makes sense. But what if you're in a bad way psychologically or spiritually, or whatever you have is just causing anguish and suffering that isn't readily fixable? What kind of approach can we initiate? Now, this was actually inspired by Dame Cicely Saunders. Dame Saunders was the founder of the modern hospice movement, and she said, you matter because you are you, and you matter to the end of your life. And I thought to myself, years later, that's, by the way, the philosophical foundation of palliative care. That expression, it's if it's not hanging in the hospice wall, one day it probably will be, because it just becomes sort of this universally embraced kind of adage of what palliative care is all about. But what it doesn't tell you is, well, how do you do that? How do you help people feel like they matter? So I thought, well, if intensive care is for people who are physically really ill, intensive caring is for people who may be feeling they're in a place where, in essence, like I said, that my gentleman, breathing has become redundant. And I realized that is a terrible slide on a small screen. So don't worry about it. This is not meant to be a test of visual acuity. But let me tell you there are 5 elements of what I call intensive caring. So the first element, and you can see it like in bold, huge letters there. The first element is non-abandonment. So again, I was saying, healthcare providers are just people, and we don't like to feel helpless any more so than anybody else. I mean, families often struggle with feelings of helplessness. It's one of the things that makes being a family member for somebody who is ill so challenging, because you don't know what to do, and with every fiber of your being you want to take away their suffering. So the first tenet of intensive caring says, despite you're feeling helpless and impotent and not knowing what to do, non-abandonment, show up. I mean, and although that sounds a bit cryptic, it's really crucial. Show up for your patients, and as a patient, you want somebody who is going to show up, be present, be attentive. Even if it can't be fixed. Dame Saunders also said, by the way, suffering is only intolerable when no one cares. So be that person who shows up so you can care. The second element of intensive caring is acknowledging personhood. In other words, if you're going to be there, take an interest in who this person was, who they are, who they were, who they try to be. In other words, that's kind of affirmation. So that's what healthcare providers need to do. And patients somehow will then feel like they're still a part of things, whether it's a conversation, some acknowledgement about, I know my dad is 95 years old. One of the most joyful things, and I can see his face light up whenever you say, well, let's, tell me about that. Or, what is your memory of that? And it opens up this incredible, history book, 95 years and counting. It's important. In fact, there's a psychiatrist, Robert Butler, one of the founders of geriatric medicine, and he introduced and studied reminiscence and says, so reminiscence, it is giving people an opportunity to reflect on their life. I think there's also a process of psychological integration, but it also is an affirmation. That memory that you dug out of the archives from 60, 70, 80 years ago, it matters. Okay, the third element is about, I'm going to go to the fourth one. It's about presence. Knowing that just showing up, being present, even just your demeanor. If you wait, if somebody is suffering and you say, I'm going to wait until I have the right thing to say, you're going to be waiting a really long time. But if you just understand that your presence, your demeanor, being there can make a difference, you'll feel less helpless. You'll feel like you don't have to come up with the right thing to say. Because unless you can say something to the effect that, there's been a big mistake, and actually we expect recovery to be really quickly, move along quickly, and you ought to be out of here any time. You'll be out of here anytime soon. You can't say that. So show up and just know that your presence, being there, can make a difference. The fourth element, and I realize this is too small a slide and maybe I should have done it a different way, but bear with me, we're almost done. We're almost done, and then we're going to open it to questions. So the fourth element is what I call knowing what's possible. If we are doing this work, you need to know that there are still important things that can happen. So long as that person is there and with you. We're doing a study now. It's actually a doctoral student of mine who is interviewing people who have been approved for medical assistance in dying. And we're going to their homes, or we're going to the bedside in the hospital and just interviewing to say, so tell us about what led you to this decision. And I remember a gentleman we saw recently, he said, well, this is a gentleman who's been seen and approved. He's just waiting for it to take place. He said, well, the reason I'm doing this is I'm not going to die the way my grandmother died. And he described the fact that his grandmother had kind of a crappy death. And I said, well, how long ago did your grandmother die? And he said, well, 30 years ago. I just about fell off my chair. For 30 years, he's carried this template in his brain of what dying looks like. And it's not a map that he wanted to follow. So even knowing at the bedside, whatever time remains, what families are bearing witness to is going to form a template that they're going to carry forward and is going to inform the way they feel when their time comes. And then finally, what I've called humility. If you're going to be entering into this kind of work, as healthcare providers, you need to understand that we don't have all the answers. In spite of which, we need to know that being present makes a difference. I think I'm going to skip that. So my closing remarks are this. Last 2 years ago now, this gentleman wearing the spiffy orange tie, he's the dean of medicine. He always wears spiffy ties, bow ties. He likes that. He had asked me to give the white coat ceremony speech. Which I did. And actually, I don't know what I feel more proud of, the fact that he asked me to give the white ceremony speech, or that I figured out how to make a QR code and stick it into this PowerPoint slide. I'm not sure what you're supposed to do with it, but if anybody knows what to do with it, I think you take a picture of it and it'll show you the whole speech. But just a couple of things that I said to the medical students that might resonate and be a good way to kind of end this talk. And I think it might resonate with healthcare providers and with patients alike. I said to these new students, I said, strive to be more than human body mechanics, strive to be healers. I then said, the way we are with patients and our attitude towards them will profoundly shape each and every clinical encounter and their illness experience. And then finally, I said that patients will not care what you know until they know that you care. And with that, I think we've come in almost on time. I think we have about 15 minutes or so, more if anybody is interested, but about 15 minutes for question and answer. This is who I am, and this is how to get hold of me if you can't find any of the articles. And thank you for coming this afternoon. Questions? Oh, and I'm going to come down so that I can get a little bit closer and hear things better. You're a familiar face.
Yes.
I'm sure I've seen you before.
So, I walked into a classroom in 2010.
Thank you.
I walked into a classroom in 2010.
Is that working? That shut off.
It's not working. Hi, my name is Bertha, and I'm also a nursing student from CBU. I walked as a healthcare aide, and in a few months I'll be a registered nurse. And during my career path, I have developed this idea that I carry a vase with me, and in this vase I carry with me all the thank yous, all the education, and I envision them as flowers. And I found that my vase was getting a little empty, and so coming here and hearing you speak has helped me fill that vase. And with every patient that I meet, I believe that I can make a difference in dignifying them with all of the examples that you've shown. So thank you so much for doing this. My question to you is about patients who loved but were never loved back, the lonely patients who come into palliative and have no one, and perhaps they can't even speak for themselves. How would you, what examples can you share with us in order to dignify them and try our best to see them through their own lenses when we don't have family or anybody to tell us? Thank you.
I've never been compared to a flower before, so this is it's a whole other level of affirmation. So, you know, life is so difficult for so many in so many ways, isn't it? And you're right. There are some people who, well, there's two stories that come to mind. I'll see if I can remember both. But so the first that comes to mind is a woman who, again, this is from that study that we're telling you about. So this is a woman, she's got bad illness. She has sought out MAID, being approved for MAID. Selena, my doctoral student, and I go to her apartment and we do this interview with her. So the story, and I'm going to kind of abbreviate it because I don't want to take up too much time, but the story is basically this: she's lived a life in which she hasn't felt loved. Her mother died young. Her father remarried. The step family never really kind of took to her. She left the family home as quickly as she could. She described a series of relationships that all went kind of bust. In every instance, she felt she was the one rejected. Never saw a psychiatrist, never had any kind of psychiatric history. One time had made this very vague suicidal gesture that ran a dull knife across her wrist after a boss admonished her for something, but that's it. She gets diagnosed with this bad illness, and the first thing she decides is, I'm going to get MAID. And I said, well, and how did you come to that decision? She said, well, you know, I've gone through life. People obviously don't really like me. I'm not sure that I'm, that great a person, anyways. And this is my way out. So, oh, that's really interesting. Anyways, so we talked about that, and at one point I said to her, "Well, why aren't you dead yet? I mean, why hasn't this happened?" And she said to me, "Well, the palliative care nurse team has been visiting me. They kind of seem to like me and I like them. And you know what? For the time being, I'm okay." So, a true story. I mean, again, I remember when we completed that interview, we went down to the lobby of the apartment she was in. I turned to Celine. I said, "There's an interview you'll remember the rest of your life." I mean, like, what an incredible story. And I remember, and the other story that comes to mind, and again, this goes back many, many moons, when I was at the very beginning of my career. I was working in New York at Memorial Sloan Kettering. I was on the neuro-oncology unit, and there was a man who was, he had a very complex history, and a variety of psychiatric diagnoses, which meant in turn that he was estranged from his family, and the staff just found him very difficult to deal with. And I think I was consulted because they wanted somebody else to deal with it. The first time I met him, he said, and he was dying, he had a primary brain tumor. And the first time I met him, he said, he wanted me to help him die. And again, this was in the late 1980s. Again, there, no legislation around hasten. So I said, no, I really can't do that. Not only is it not legal, but that's not where we're going to go with this conversation. I said, but if you would like me to come in and see you, and just kind of be here and talk with you, and I'm prepared to do that. So he said, well, whatever, fine, let's do that. So, and he was a man who complained about everything and everyone. And I would meet with him and getting to know a little bit about his life and a little bit about his history. And periodically he would complain about the staff. And one day he was complaining about me, saying, this is ridiculous. I mean, you come here and what are we doing this for? And I said, you know, um, you're under no obligation to meet with me. We can stop our meetings. He looked at me and he said, are you crazy? He said, this is the only thing that's keeping me going. So, I mean, I'm not trying to be trite, but in terms of the answers, I mean, I think, it comes down to an attempt at connectedness. And I sometimes think of this man and think, had I said, well, what if we were in a different era and we said, well, there is a different option. Would the end of his life, as the medications were, kind of going through his system, would the end of life somehow be an affirmation of exactly what he thought? I am useless. My life has been kind of a waste of time, and I and the world would be better off if I were dead. I mean, I have thought about that. So I think therapeutically, at a minimum, thinking about intensive caring, show up and try and make a connection. I think that is the foundation. That's where it starts.
Thank you.
Right? Came late.
Actually came early.
Oh, you came early, but you didn't want to say, do you have a question?
So my question is, sometimes I feel like it's easier to see the patient through their diagnosis or whatever has brought them in, rather than them as a person, kind of like as a personal boundary. Because like some of us going into this career, like very big empaths, and like let's say if we have like 4, 5, 6 patients to see a day, and all of them with different stories, you get to know them personally day after day. It's like you create that personal bond with them, and by the time you see them go, it's like part of you has gone with them. So like on the long run, how can we prevent that emotional burnout from, yeah, from
It's a
trying?
great question. It's a perfect question, and one that comes up. I think I better go back to the front so you don't all leave here with a sore neck. So we could spend a lot of time kind of drilling down into the details of that and how to kind of navigate that. Um, I had a colleague who was the head of our palliative care program years ago. His name was Mike Carlos, and he was just an extraordinary palliative care doc. And what he would say about this was, if you're going to be working in the kitchen, you have to be close enough to the stove so you feel some of the heat, but you can't be so close that you're feeling, burned. In other words, compassion is this kind of it's this empathic dance. If and there are risks on either side, so if you are so close that you are owning the patient's suffering, um, you're gonna feel pretty weighed down and burnt out, quickly. Um, but if you're so distant from what's going on, from the human experience of what's happening, you turn into somebody who is kind of robotic, you know. And I don't know if I mentioned this morning, I had a nurse who worked in nephrology tell me that after a number of years, she realized that she looked at patients as if they were kidneys on legs. And she said to me, when I got to that point, I realized that I need to change something because she realized it wasn't good for her. Because one of the symptoms of burnout is this kind of emotional disengagement. You just become kind of like robotic in what you do. So it's important that you, on the one hand, be close enough that you can be aware of somebody's suffering, but you can't be so close to it that you are overwhelmed by that suffering. And the other little, just sort of an anecdote, just to give you an example of this. So, dignity therapy is a way of helping somebody create their generativity document, create a legacy document. So, one time I was referred a young woman, and the details of this are like overwhelmingly tragic. She was young, it was a young marriage, she had a young child, and she was now dying. She was, I can't remember how old she was, but she wasn't more than 30 years old. And when you think about stepping into that, you think, well, give me a break. It's just too overwhelming. I would feel, you'll feel emotionally kind of decimated by even coming close to that. But here's the thing. Um, she came to me saying, I want to do this. She had heard about it through her social worker. She said, I want to do this because I realize I'm going to die before my child has any possibility of remembering who their mother was. And this is a way of trying to create those memories. Well, I can do that. That sounds good. So, first of all, I entered into this. I wasn't feeling like burdened by what she was going. I felt really kind of, I had the right tool, and when you have the right tool, it feels completely different. Well, the right tool in this instance was to sit down with her, and she was magnificent. She talked about her childhood, formative experiences, what her values were, kind of key wisdom that she would hope her daughter would. She wasn't trying to manipulate her daughter and saying, here's the cookie cutter that you need to sort of follow, but just kind of guidance. And she even gave her husband permission to remarry, so long as his partner would love a child the way a mother is meant to love a child. At the end of the whole thing, it was a magnificent thing that she did. And at the end of it, I did not walk away from it feeling kind of depleted and like, oh my God, like, how can I do another one of these? It was a very empowering experience because you're doing for the patient exactly what they need done. So I guess, think of, it's a delicate and difficult dynamic, and it's a real one. How do you do your work, do it in a way that you're in touch with what's going on, but not in a way that somehow what's going on emotionally for the patient is something that you feel kind of buried under the weight of. So those are a few kind of remarks to maybe get you thinking about that. Okay, good. As I said to the group this morning, I'm a psychiatrist, so I'm very comfortable with silences. So take your time, let the question kind of rise up. Yes.
Have you run into any experiences throughout your life, or throughout your career, throughout throughout your career, where you've encountered a difficult lens of like cognitive impairments with patients, and then how that impacts the dignity of care we get?
So a great question, and is everything that I've said, does it kind of get negated when somebody is no longer cognitively intact or cognitively capable or less than cognitively there? And the answer is, until the person has taken their final breath, and even beyond their final breath, before the patient has died, and even after the patient, treating people with dignity turns out to be very important. For all of the, besides the humanistic reasons and all of the empirical reasons that I've shared. But let me give you something that is a bit more kind of tangible. Again, when you're old, there are so many examples you can choose from. So here are a couple. So one, I was looking after a gentleman years ago. He was a professional musician. He was a violinist. And we had spent a lot of time together, and what was important for him was for people to recognize that he just wasn't didn't want to be seen as an old man who was dying of whatever the terrible illness that he had. I don't remember the details of his illness because it's generic, just another way. But I remember him in terms of personhood. So he's now in hospital. He's on his deathbed. He's near the very end of life. I know that he recognizes me. He can hear my voice. He recognizes me because I'd spent a lot of time with him. There's a nurse sitting at the bedside taking notes. And I thought to myself exactly what your question. I said, okay, what do you do now? How do you initiate dignity conserving care when I'm not even sure that he can, well, I think he can hear me, but obviously very compromised. And I turned to the nurse and I said, did you know that Charles was a professional musician? So she stopped doing her writing notes. I said, oh yes, he played with, and I named off all of the orchestras of the world that he had told me about, and all of the incredible soloists, Ashkenazi and Vladimir Horowitz, and I probably made up a few that just because I couldn't remember them all. So what was interesting is that she stopped and seemed very impressed. He broke out in a full body blush. He loved it. It was cool. This was very cool. And later, and this is a true story, I remember hearing her at the nursing station saying, by the way, did you know that Charles used to be and I thought, okay, that's the trick. Putting personhood on the radar. It doesn't matter. Was Charles aware of it? It turns out, I think in that moment, his full body blush suggested that he was. But even if he wasn't, for the nurse, it changes the tone of care. At the risk of kind of going on and on, the other thing that comes to mind, there's a body of literature on something called elder speak. I don't know if you've ever heard about it, but elder speak is this kind of a pseudo-saccharine, quasi-affectionate way of talking to elderly people that basically is very generic and dismissive. So rather than referring to somebody by everybody is honey or sweetheart. Now, if everybody is honey or sweetheart, basically what it means is that nobody needs to remember your name, And if you call me, and if I'm honey, everybody's called by honey, there's nothing special about the way you're treating me. So there have been studies that have looked at elder speak and found that when you change the behavior of the healthcare provider in the context of elder speak, behavioral discontrol becomes lessened. So I would say to you, yes, it's being cognitively, having a patient who's cognitively intact, gives you some currency that is very helpful. But when those kinds of approaches no longer have currency, it doesn't mean that dignity is less important. It means that you just have to look at other avenues to find a way of preserving it.
Well, thank you. Yeah, we're not seeing any further questions, so that's good. My name's Corey Stewart. I'm the Executive Director of the Hospice Palliative Care Society of Cape Breton County, and I think we can all identify with being a patient and our desire to be treated with dignity at that time. So we say thank you very much for your thoughts, Dr. Chochinov, on this afternoon. And we as the society, we were very excited that Dr. Chochinov accepted our invitation to be here. And because of our excitement, we have him scheduled all day. And we're working him very hard. So we do have to wrap things up this afternoon, but I do want to say thank you to all of you as well for coming out. And once again, please help me thank Dr. Chochinov.